Hello and welcome everybody. I'm very pleased to say that to introduce Dr. Unnati, and this is the first webinar that we've actually done on PCOS, here we go. I've already got my teeth the wrong way round. I'll get you, Unnati, to say it.
Polycystic Ovary Syndrome.
There we go. Well done. I've been practicing it and it all comes out fine until I press the let's go live. So apologies. So yes, we're getting, I was just going to say, we don't do loads that are specifically female. And then sometimes I think, gosh, we need to really dive down into these issues that affect so many people. And please correct me if I am wrong. It is a chronic condition or a chronic concern, isn't it? That I didn't realise how many people it affected.
So it actually affects more female patients than we probably know. It's a multi-system condition and it is chronic, so there's no cure for it. So once you're diagnosed with polycystic ovarian syndrome, then there's ways of controlling the symptoms and etc. But there is no cure. But it's a problem that affects the ovaries, but it will also have an impact on our skin and hair. And also it particularly affects women who are of reproductive age, so childbearing years, and then it can impact the metabolic function. So when we look at prevalence, we estimate that about 10% of women suffer with PCOS. But what I normally say to my patients is if we take the entire female population, a third of those women will have multiple cysts on their ovaries if we were to do a scan on them. But only a third of those women will actually have the syndrome, where they have the multiple cysts on their ovaries, but they'll also have the characteristic features of polycystic ovarian syndrome. And the difference between the two is that the polycystic ovarian syndrome, so PCOS, is related to future health concerns that we need to be cognizant of. And that's why it's important to get the diagnosis correct. Whereas if we just have the cysts on the ovaries on their own, then actually long-term consequences of health issues is not there. And so that's why it's important. So when we look at diagnosing women with it, as a doctor, we have to be mindful of the presentation that women come in with, and there is a diagnostic criteria that we use. So there's 3 symptoms broadly that we look at for polycystic ovarian syndrome, and you need to have 2 out of the 3. So the first one would be that you're not having frequent menstrual cycle, or you might not be bleeding at all. And that's the most obvious one, isn't it? So normally we'd expect to have a cycle every month. So we expect to have 12 in a year, and we may not be having that. And diagnostic criteria is less than 9 bleeds in a year. And then there's the other hallmark is going to have high androgen levels. So that's going to be things like testosterone. There's another blood test called androgens. And they're basically, the androgens are the male hormones that we all have a little bit of. So even female patients have a little bit of, but not too much. And when we have it in excess, we get the hirsutism or excess hair in the male distribution. We might even get the male pattern baldness and acne. And those 3 can have a huge psychological impact on female patients. And then obviously the third important criteria is having multiple cysts on the ovary. And the criteria for that is having more than 12 cysts on one. So the diagnostic criteria is pretty simple. But people often say, why am I not diagnosed? I know that was a question that you asked me. Why is it that people may not be diagnosed quite quickly, or people might be underdiagnosed, or and the reason is that women may not actually have such severe symptoms that make them present to the GP, or one of the other things that can happen is that women may have mild symptoms but have fertility issues. So that's the key for a lot of female patients, is that when they try to get pregnant, they're struggling, and that's when the diagnosis might come in.
So do you know what I haven't asked you, and because we've just whizzed along into, because it's really interesting hearing how everything, all the different symptoms, but just if we just roll back a bit, is just quickly ask you about yourself and and your particular interest in this subject, so people know who you are.
By background, I'm a general practitioner, and I specialise in women's health, not obstetrics, thankfully, but gynecology was an interest of mine, and dermatology. So, when we look at the range of problems that women come in with, intimate health is an area that can be very difficult for them to talk about. And what always fascinated me was that patients I'd known for many years, there was that one thing that they just wouldn't tell me, and it was always to do with their reproductive system, or some kind of urogyne issue that they were just so embarrassed to talk about. And so it piqued my interest more, that how do we start those conversations with our patients so they feel they can actually disclose really sensitive and personal information, so we can try and find a solution. We may not be able to fix everything, but there's always some solution to improve quality of life and intimate health as well.
So yeah, I mean, it's interesting that you say that, because one of the questions I was going to ask you is, what sort of age do people present to you with the concerns? Now, you're saying that a lot of it, people don't realise that they have the condition until they try to get pregnant. But clearly they've had the symptoms, and as you said, they don't talk about it. So that a lot of these ladies or these women have had the problems for a while, but they haven't gone to see the doctor. They've just done the usual sit there in silence or stand there in silence. Because
symptomology varies in severity.
So, right.
And that's the key. Like if a patient is managing their symptoms and it's not really bothersome to them, then they're not really going to attend a GP appointment, because it's not something that they consider to be an issue. And then we've got to think about different ethnic minorities. Some of them find it very difficult to talk about intimate health concerns or reproductive concerns until perhaps fertility is really at the forefront of their concern, because they can't get pregnant. And then we also have, the use of contraception in younger women is very common now. They might be using it for contraception, or they might be using it to help regulate their cycle. But when you are on the contraceptive pill or any form of contraception, it will mask the symptoms of polycystic ovary. So you may not actually have the symptoms until you've come off the pill. And, as much as it takes time to settle onto contraception, and we normally say 6 months, when you stop your contraception, it takes about 6 months for your body to settle off it as well. And so there can be that delay in diagnosis or attendance for symptomology because of something as simple as not knowing because you're on contraception. So it really does vary. And the key thing is though, when a person presents, if they know what's meant to be normal, and we can flex on what normal is. So in medicine, nobody ever fits the textbook definition of normal or an illness. And there's always going to be that flux in presentation. But if we simply put it that if, we clinically, I would want my patient to bleed once every 3 months. That's safety, because when we don't bleed on a monthly basis and we get this thickening to the lining of the womb, that if that continues on a regular basis, that is a risk factor for endometrial cancer later on in life. So having a healthy lining of the uterus is really important. Now, what I would say to your audience is, if you're having a monthly bleed, then that's great, because that's what we classify as normal reproductive cycles. But if you're not bleeding that frequently, or you're not bleeding at all, that does need to be looked at. And when you present to your GP with something as obvious as I'm not bleeding every month, or I'm not bleeding at all, or I can't get pregnant, we would then implement some basic investigations, which would be an ultrasound scan to look at the ovaries and the lining of the womb. We can either do that through the tummy, like a pregnant woman having an ultrasound scan. It doesn't give the best views of the ovaries, so actually a transvaginal scan or putting a probe into the vagina is a lot more useful for us. But, and if you've never been sexually active, that can be quite daunting as well. So this young girl goes to their GP who's never been sexually active, and they're told, oh, you need to have a probe in the vagina to have a look at the ovaries. It needs a little bit more of a further conversation. You can certainly have that transvaginal scan done if you've never been sexually active, but there's got to be a discussion around it so they know what to expect, and they know they can stop at any time. So ultrasound scan to look at the ovaries, and then a blood test to look at the hormone levels, where we would look to see hormone imbalances, but also particularly the androgens would be high. And that's the diagnostic criteria that we would use. And then we look to see how do we manage the symptoms of that woman, depending on what she wants us to do as well.
So just going back a bit, we did a webinar a little while ago about going for smear tests and cervical cancer, and and it'd be interesting if you've have experienced the same. A lot of young girls, they have they get the injection or whatever it is, when they're younger, and then they feel that's it, we don't need to be tested for anything else, and then they miss their smear test, and it's that education thing. But what that also does is, if people are not used to, as a young girl, is having transvaginal
anything
explorations is what I want to say. But,
right.
it puts people off, doesn't it? And you're just thinking, gosh, as a woman, it is, these things happen to us, and as soon as, you're pregnant, you have a lot of tests and all of those things. But it's, as a young girl, it is daunting, and it is important for people, I believe, to get used to these things. And as you said, exactly, that's the problem, is that people are concerned.
But it's not just young people. I deal with intimate health concerns and genital urinary syndrome of menopause, a whole different topic, menopause. But women who have been sexually active, had the vaginal deliveries and been poked and prodded, even they will not talk about their intimate health concerns, because it's just a sensitive subject. And when they come for examinations, having had all of that in their 40s and 50s, even they're struggling. So somebody who's been sexually active, somebody who has had multiple examinations down below, if they're struggling, I wouldn't doubt for a second that a younger female who's never been sexually active is going to find it very, very daunting.
Yes, absolutely. So we've got to, I think we were talking about the symptoms that people can have, and then we now go on to the testing that can be done, which is either on the tummy or internally.
Internally is always going to be better to visualize the ovaries. So, if that can be done, but it's for the young girls out there who are listening to this, if you've never been sexually active, then it would be worth trying a transabdominal scan on the tummy first to see, can we see the ovaries? And if we can't, then it would be a counseling conversation to say that this is what's involved. It's just a probe that goes, I say just a probe, but it is daunting. It's a probe that goes into the vagina. It's cold. It feels like pressure. It's not as uncomfortable as having a smear test done, because there the speculum's being open, whereas this is just a cold probe. And they push into the left and right because the ovaries sit on either side of the abdomen, of the pelvic cavity, and they try to visualize it. But it's always, conversations are needed, right? It's about when you're examining your patients, if you talk to them, you can calm them down, explain to them what's going on. Diagnostics is really important, blood tests, and then management of symptoms comes down to the symptoms that I, as a doctor, want to control, because I've got to consider the long-term health concerns and the symptoms that patients would want to focus on, which is probably more the visual things of skin and hair, or trying to get pregnant. So, the menstrual irregularities we've spoken about, ideally, I would want my patients to bleed every 3 months at least, if not monthly, because I'm going to protect the lining of the womb. Fertility issues, if we don't bleed, we've not ovulated for 14 days prior. And so patients with PCOS will often find it's difficult to become pregnant because of that decreased ovulation. But at the same time, a patient who presents with PCOS, if they're not ready for a family, they do need appropriate contraception. So I'll kind of describe that to my patients as subfertility rather than infertility, because it's not that you can't get pregnant, it's just that you're going to struggle. And then the hirsutism, the excess hair, and male pattern baldness, acne, we can learn to manage that. But insulin resistance is the other hallmark of PCOS, which is so important that patients understand. So insulin resistance is really common. We estimate that 75% of women with PCOS will suffer with insulin resistance. And that's regardless of what their weight is. So we know that with excess weight, particularly around the waist, there is an increased risk of insulin resistance. And what that means is that the cells that use glucose as a source of energy, so your muscles, fat, and liver cells, they don't respond to the insulin. So they're not utilizing glucose. So your body's response is to produce more insulin to try and get these cells to take on the glucose. So high levels of insulin actually increase the risk of us developing pre-diabetes, diabetes in pregnancy, and type 2 diabetes later in life. But it's also associated with this higher risk of what we call metabolic syndrome. And metabolic syndrome is basically a cluster of having an abnormal lipid profile, central obesity around the waist. And we know there's a direct correlation to waist circumference and fat around the organs, or what we call visceral fat. And then there's also this increased risk of stroke. So our patients with PCOS, these are the long-term consequences that we need to mitigate from a young age. And interestingly, the higher level of insulin in the body also increases the amount of androgens that your ovaries produce, which then just will make the PCOS symptoms worse. So insulin, it's a bit of a vicious circle. And insulin resistance is something that's really key. But all of these symptoms, the four main categories of symptoms, some women may not have any that they present to the doctor with, and others will suffer with a lot of them from that entire array, and the severity will vary. So management for me would be looking at keeping my patients safe immediately, but also for the long term.
Oh, okay. And does it present more in different ethnicities at all?
Not necessarily, but it can run in families. So, but I think it's the ethnicity presentation to me, in my mind, seems to be more around openness to talk.
Yes, and that's what made me really think about it. So maybe a lot of, and I suppose also then you get to the problem, particularly in certain communities where language is then a lot of the issues in going to a doctor to explain something that's very intimate, and you don't have the right language to explain it. It must be very, very difficult.
And also, the gender of your doctor. So if you're not comfortable speaking to a male doctor, female patients have got every right to request a female doctor, and vice versa. But often people find, they think, that somebody's going to think I'm rude, or I don't want to appear difficult, or access might be a problem because really they're struggling to, it might be a practice that's very heavy in male GPs, for example. But, practice nurses are a source of information as well. And there's a lot of female nurses out there. So there's another way of accessing them. But online resources as well are really important.
So you mentioned two of the very obvious side effects that everybody else can potentially see is acne in their hirsutism. What are and you said that I'm not sure if you actually said they can be easily managed. Probably easily is not necessarily the right word, but that they can be managed. And how would you go about managing those concerns?
It will really depend on whether the patient who presents to us with PCOS is trying to get pregnant or not. If they're trying to actively get pregnant, then to be honest, there's not much that can be done to manage them at that moment in time. The hirsutism and acne tend to be as a result of higher testosterone levels running around. Now, it's really important to say when we talk about acne generically, so just put the PCOS to the side for a second, acne is not necessarily associated with high levels of androgens. It is the end organ response, which means in most people with acne, we could do a blood test and their androgen levels would be absolutely normal. It's just the sensitivity of their skin in response to what they have as a normal range is overly sensitive. When we look at PCOS particularly, one of the diagnostic criteria is that actually the androgen levels are high. So it's just worth making that really clear that somebody who has acne doesn't necessarily have PCOS, if that makes sense. But when we have this acne, we can, if our patient doesn't want to get pregnant, we can decrease the level of androgens in their body by putting their ovaries into a quiescent sleep mode. And we can do that by putting them onto contraception effectively. So if it's safe for a patient to have contraception, then particularly the combined oral contraceptive pill, which has the estrogen and progesterone in it, is really useful because when you have a high dose of the estrogen, it will actually put the ovaries to sleep. And if you put the ovaries to sleep, they're not going to produce that level of androgen. And there's a particular pill called Dianet or Diane, which people have often heard of, which one of the ingredients is actually an anti-androgen. So it's very useful in terms of controlling cycle, but also really treating excess hair or acne. The only thing about Dianet is that it does have a slightly higher risk of venous thromboembolism, or that's kind of your risk of clotting. So you really shouldn't be on it long term. And the idea is that you would start that with somebody who's got severe acne or hirsutism, and you would look at taking them off it after 4 to 6 months but putting them onto another oral contraceptive pill that has a lower risk of the clotting issue. And the nice thing about going onto the oral contraceptive pill is that it provides you with contraception if you're not trying to get pregnant. And the combined pill will give you a regular cycle, which is predictable, which is quite nice. And if you choose to go on the progestogen only pill, because, for example, you may not be able to take the combined pill safely if you have migraines with aura or a contraindication to it, the progestogen only pill will suppress the ovaries to an extent that it can put you into a slightly more kind of little bit activity, but not as more suppressed rather than shut down, let's say. But a lot of women end up not bleeding on that pill, but their lining of the womb is still protected because there's no thickening of it. So there's you don't bleed because there's no lining to shed, if you like. And so that's a nice thing about female patients who have PCOS, is that if they want to have contraception, they're not trying to get pregnant, we can actually do something about the acne and hirsutism in that period of time. And the other thing, metformin. Metformin is, and this can be taken in women that are trying to get pregnant as well, because metformin does a lot of different things. It's actually a medication that's used in diabetics, and it's one of the first line medications for our diabetic patients. So in PCOS, it's an out of license indication. It means it's not been licensed for use, but it is commonly used by doctors. And it decreases the insulin resistance. So it helps to promote sensitivity to insulin. And it will, therefore, if we can decrease the insulin levels, we can actually bring those androgen levels down. So, and actually, metformin will help you start ovulating again. So if you are trying to get pregnant, it's great because you're going to ovulate. And if you're not trying to get pregnant, it just improves your risk profile for future issues around insulin resistance. And
no, that's all set. So there's quite a few things that you can get, but if you're trying to get pregnant, so if we now move on to the fact they're trying to get pregnant, what can be done to support those people?
So in terms of medication, it's going to be the metformin or fertility. So there's not many options in terms of medications, but one of the most important things for any patient, whether you're trying to get pregnant or not pregnant, is your lifestyle changes and modifications and the healthy lifestyle that we choose. So that is the hallmark of management for any patient, is going to be maintaining a healthy weight as best you can, eating a balanced diet, not smoking, not drinking excessively, doing the regular exercise, because that's going to improve your insulin resistance, so decrease your natural androgens, improve your parameters for risk factors for stroke and heart disease, etc., improve your lipid profile. And we've got evidence to show that if a patient loses 1 to 2 kilograms of excess body fat, they will actually start to see their cycle starts to regulate itself naturally.
Right.
And weight loss is really important. And we suspect it's as a result of decrease the excess weight means that your insulin resistance improves, which means that your androgen levels go down and you start to regulate yourself a little bit.
So, and as you said very early on when we were talking, it is looking also at people's long-term health, and you can't get away from the fact of weight management and smoking.
100%.
They say, everything always kind of comes back to those two major things.
Comes back to those two major things, absolutely. The impact, so in terms of PCOS, we know that they're at risk of metabolic syndrome. So we know that in severe symptoms of PCOS, patients will have the abnormal lipid profile, and they'll have that central obesity, and they have that higher risk of stroke. But if we look at patients who are overweight anyway, and they have that central obesity, they're going to have that potential high blood pressure as well. Smoking increases the risk of blood pressure, diabetes, as well as the cancers, but it increases the risk of heart disease. So you look at all of these individual things, the amount of fat that we carry, whether we smoke or not, how much alcohol we have, these are all independent risk factors for heart attacks and stroke and diabetes anyway. And then diabetes is a risk factor for stroke and heart attacks. So they are all interlinked. So one of the things that we need to look at is promoting lifestyle changes, how we eat, how we move, and our exercise that we do, and also our sleeping patterns and how mindful we are in terms of all of those two things, because that's what's going to promote that healthier lifestyle. And people talk about fad diets. It's interesting because I've had patients come to me about intermittent fasting, or what about 5-2, and you know, these diets, they're basically, the way people should look at that is what we decide to eat and what we ingest is key. So the Mediterranean style diet, your leafy green vegetables, your oily fish, your fruits, your whole grains, your low fat meats, those are the choices that are healthy. So if you want to do intermittent fasting because that works for you, like for me, for example, my brain is much more agile if I don't eat breakfast. So
really?
Yeah, so if I eat breakfast, then I kind of feel a bit more, oh, I'm hungry 2 hours later, my brain's not working. But if I just have black coffee for my breakfast in the morning, I can just get through things a lot quicker. But that's my body. And so the key thing is to listen to your own body, because some people feel they have to have breakfast to be able to function. But if you're going to do the intermittent fasting, for example, or the 5-2 diet, it doesn't mean that on the times that you're eating, you can eat your pizza and junk food. That's absolutely not the point. The point is to have that healthy pattern of eating that's right for you, and make those healthy choices of what you ingest as well.
And habit, just getting into the right habits, isn't it? And to repeat.
Yeah, and there are a lot of so during the pandemic, you know, Saxenda came out, the skinny pen, which is a once a day injection for weight loss, and then Ozempic came out, which is a once a week injection for weight loss. These are diabetic medications that hits the market quite hard, and you know, people can go online to online pharmacies and get a prescription. It's got to be done the right way. There is nothing that's going to bypass the choices you make in your life, the choices you make when you eat, and how much exercise you do. And when it comes to exercise, you know, often what I say to my patients is it is about motivation. It is about habit building. You know, if you're going to set an hour aside to exercise, I think the best investment you can make into yourself is to get a personal trainer. I know me, for example, if I put an hour aside to exercise, it's a half-ass attempt at exercising. Whereas if I have a personal trainer who's not letting me stop, when I would easily have stopped, you know, that the output from that hour is going to be a lot more beneficial than something. So it is actually those kind of small things that will really make a difference to your ongoing future health.
No, it definitely is really important. So we've looked at, I was just sort of running through our little crib sheet. We've looked at the symptoms and, you know, how you can manage the symptoms. So managing the symptoms are very much, we can look at medication, particularly medication if we're not looking to get pregnant. But if we are looking to get pregnant, there are still options. And then on top of that, obviously, the healthy lifestyle, which underpins everything, really. And so one of the things is PCOS nutrition. So we've obviously basically just touched a little bit on healthy lifestyle. Is there anything specifically on the nutrition front that we should be aware of?
Nothing other than having that healthy diet. So the Mediterranean style diet, a low glycemic index diet, low GI diet means the type of carbs that you choose to eat. So choosing more complex carbohydrates than your simple carbohydrates, which simply put, if you're going to have bread, choose brown bread, not white. If you're going to have potatoes, choose your sweet potatoes, not your normal potatoes. Basically, a complex carb takes a lot more energy to break down. So you get more sustained release, and then you're not going to get that peak of glucose and therefore that peak of insulin. So it actually helps with the insulin regulation and glucose regulation. There is some evidence to show that certain supplements like magnesium can help, but they're not proven clinically in terms of it's a treatment for. So to my patients, it's always going to be healthy lifestyle choices of what you put in your mouth. You know, an A to Z multivitamin that's got as long as you're not trying to get pregnant, because you don't want vitamin A in that instance, but, you know, a kind of multivitamin that gives you your nutrients and minerals that we're not going to get from our diet necessarily. Having a good amount of fatty acids in what we eat is really important. And sleep, you know, we think about diet and exercise, but sleep is really important as well, because when we don't sleep properly, you know, cortisol levels change, and then that can impact weight, etc. And, you know, my patients, if you want to do intermittent fasting because that works for you, happy days. If you want to do the 5-2 diet and you can do a 500 calorie deficit for a day, happy days. I can't do that. I don't like the thought of not eating, but I like to intermittent fast. It just is what my body wants. But not everybody's like that. So listen to what your body's doing and make the right choices.
Okay. One last thing. So as you said from the very beginning, it is a chronic condition. It doesn't go away. Once you've got it, you have it for life. When you've had children, you know, I don't know if symptoms get worse while you're having children. I don't know if there's any. And then once you've had your children, does it sort of, I was going to say come back again, because obviously then you'll notice if you're having periods. What happens as you age? Does the PCOS change?
It changes. So yeah, so when you're pregnant, you know, the ovaries aren't going through their cyclical change anymore. So if we go back to biology GCSE, or back in the day, and they taught us on this female cycle of hormonal fluctuations, that's the monthly cycle. And so when we become pregnant, those hormonal fluctuations are not happening anymore. And we're not getting this kind of ongoing like cysts on the ovaries. Everything just becomes quiet, if you like. And actually a lot of women, it's interesting because some women will find that in pregnancy they get a flare up of acne, whereas other women will find that their skin's actually really good in pregnancy. So how we respond to our hormones is very, very much individual. But effectively pregnancy will just kind of override the whole issue of PCOS, but the underlying risk factors are there. It has not gone away. So you're still at risk of metabolic syndrome. You're still at risk of the diabetes in pregnancy. So gestational diabetes we touched on, and that's where you develop diabetes in pregnancy. So all of those things are ongoing risks. So women who have PCOS will struggle to become pregnant, and when they are pregnant, there are slightly higher risks associated with it, like getting diabetes in pregnancy. So continuing those lifestyle choices and maintaining as much good health as you can is so vital. And then when the pregnancy ends, and you know, if they carry on breastfeeding, then obviously that will impact the cycle. But when they stop breastfeeding or they don't breastfeed and the cycle starts to come back again, then their ovaries are active again, and then the whole thing starts up with is their cycle regular or not regular, and what are their androgen levels doing. So in that way, it's halted, but risk factors are still there, and then it restarts. And when you go through the menopause, and that's a time of life when our ovaries are starting to shut down, then naturally the level of androgen or testosterone particularly does start to decrease as we get older. So we might find that the acne or the hirsutism is not as noticeable as we have gone through the menopause. But again, certainly now we've got age to consider. So those risk factors that we talked about when you're younger, they are much more relevant over the age of 40, 50, and definitely over the age of 60.
Honestly, as a woman, all the issues that one has to face just goes on and on and on, doesn't it?
But there's ways of managing. Okay,
exactly.
There's ways of managing. For me, and the reason you asked me what interests me in women's health, part of my GP training, I didn't do obstetrics. I really didn't want to, but I really enjoyed the gynecology side of it, and actually sexual health. I trained in sexual health, and my training in sexual health, working in a genitourinary medicine clinic or a GUM clinic, taught me the importance of making my patients comfortable to speak. And I think when a doctor feels uncomfortable talking about something, their patients are going to feel uncomfortable. But if I can get my patients to a point of let's just have a conversation, that's the best place to start. And so one of the things at Nuffield that we're really pushing out is focusing around women's health issues as one of the factors as well, because it is underspoken about. There's so many problems, whether you're talking about issues around reproductive age, childbearing age, so that's going to be a PCOS or endometriosis or adenomyosis or difficulty having sex or whatever it might be, all the way through to your post-pregnancy rehabilitation or your women that are going through the change and the changes that happen and intimate health issues around that, or low libido. We've got to start with a conversation.
Absolutely. Yeah. And, we cover all of those things. And I am amazed that once you start asking people these questions, they're very happy to come forward to start. But you need to, i.e., when I say you, as in we at Talk Health, we start the conversation and people join the conversation. It's not quite often the other way around, and it is getting people to take that conversation. Just very quickly, on if you have symptoms and you're not sure what they are, and because I am ignorant on PCOS, is it something that a GP would recognise straight away? Is it a common thing, or would they think it could be something else?
So the investigations would be done. So if you're presenting with any of those broad symptoms, then investigations would need to be done, because there are other causes for not having a regular bleed, for example. There are other causes of fertility issues, of acne or hirsutism. It's not always going to be related to PCOS. But the important thing is to be able to recognize the symptoms, do the appropriate testing, and really consider PCOS. If you don't think about it, if I don't think about it as a GP, then I'll miss that diagnosis in my patient.
Right, okay.
As much as it is important for patients to feel they can go to their doctor and start talking about these things, and the more we start talking about these things and information becomes accessible, it becomes okay to have those conversations, or a little bit easier perhaps. But then my thing is about always be mindful about, for me as a doctor, I need to be mindful about what is it that I need to remember, because if I don't think about certain medical diagnoses at the back of my mind, then I'm going to miss them. And that's where I've done a disservice to my patient. And PCOS is really common. But, as I said right at the beginning, it is absolutely fine to have cysts on the ovaries as long as you don't have the syndrome.
Yeah, absolutely. Okay. So very quickly, you mentioned Nuffield, and I know that in all our promotion we've said that you're here very kindly because of Nuffield Health. I don't know if there's anything else that you want to mention about Nuffield or at this stage.
Yeah, absolutely. So look, Nuffield's premise has been to push health screening. So there's a difference in coming to a doctor because of symptoms, which sits very much in general practice. And there's a difference coming for health assessments where we're looking at otherwise well patients and we're looking to screen them. One of the nice things about health assessments and screening is that we're very much focused on prevention and healthy behaviors and changes. And so, there are different types of health assessments that patients can access through us, and some of them are not necessarily involving a doctor, because do you know what? The physiologists that we work with, the clinicians that we work alongside the GPs, they are specialists in lifestyle changes and behavioural modification. That's what their skill set is. Because it's always about counselling and coaching patients to make those changes. I can sit there and tell my patients about what a healthy diet is and what exercise they should do, but can I motivate them to make those changes? Probably not so much. So motivational behavioural change is so important, and it's one of the hallmarks of what Nuffield really specialise in. And then we tie that in with the fact that we've got the gyms across the UK, so the personal trainers. And so for me, if I was going to exercise for an hour every week, I have got a personal trainer, because I know that otherwise I'll be a lazy bum. I will not do what I need to do. That's a wasted hour. So you optimize your time to make those changes. Because the interesting thing is one as a person, when we start to see that improvement, or we start to see the waist go in, or we fit into that size dress, it motivates us to continue. So you need to give yourself enough time to see changes. So in that kind of 3 months that you're try and make those changes, invest in a personal trainer, invest in going to the gym, optimize the hour that what you're doing there. Don't back around sitting on this bike going slowly. It's not going to do anything. Get somebody who's going to push you hard and motivate you to make those changes, and talk to somebody who can tell you about diet and exercise.
And I think exactly, it's more so than ever, it's more important for people to be aware of their own health and managing it. Long gone is the idea that we used to have our own GP, that we had the same GP for years, that they knew us, they knew what our concerns were, we could go and sit, talk to them for 10 minutes or 15 minutes. That has changed and changed and changed. And so it's more important that you're aware of your own health, and the being preventative is...
Absolutely. Preventative medicine is the starting point of everything these days. There is that adage of medicine, prevention is better than cure. And it actually is so true. So if we can capture those changes early and we make it a habit of a lifetime, then we've already improved our health metrics and outputs for when we're older.
Yeah.
It's just, that's just commonsensical, isn't it? So the smoking cessation or not smoking at all would be a good thing to start with. Thinking about the alcohol that we drink. And alcohol, it is crazy how you can just be socializing on a weekly basis, and this alcohol unit just creeps up. And if you don't think about it, you're not going to ever consider it as an issue. So it's just being mindful and making small changes that will really keep you in good stead for when you're slightly older.
Absolutely. So thank you so much, Unnati. It has just been, well, I've certainly learned a lot of something that's a condition that I've been lucky that it hasn't affected me, but obviously I'm aware it's affected a lot of other people, and there might be a lot of other people out there who've got it and don't realise that the issues they've got, there's something can be done about them. And if you remotely think you might have PCOS, you can absolutely go and ask your doctor and mention it to your doctor, because as you said, the doctor may be thinking of all the other things. It could be the symptoms are symptomatic or something else. And I don't think doctors take too much offence as long as they're getting it right for the patient.
Absolutely.
Okay. So thank you very much, and it's really nice to meet you.
Pleasure.
Thank you everyone for joining us as well. Thank you. Bye.